Good morning, everyone. Thank you for, well, may not be morning. Hello, everyone. It is morning for us and really early in the morning for Dr. Doe and Brock. As we're letting everyone into this webinar and Zoom link, I just want to remind everyone if they could please place their mics on mute. You can definitely reach out to Dr. Doe and myself and the team through the chat. We will be looking through the chat the entire time. So if there are any great questions, I will definitely feed it into the lecture when appropriate. If not, we are going to reserve some time at the end of this lecture to answer any questions or any discussion. Also, we will leave any information if you want to contact Dr. Doe at some point in the future, or if you want to see him as a patient. But with that being said, my name is Edith. I will be moderating this webinar today. I am a physician assistant, and I've been working with IIH Hub since inception, and we have our whole team here today. The title for today's webinar is IIH, the optometrist role. We have Dr. Huy Do. He is an optometrist who practices in the Pacific Northwest at Kaiser Permanente, which is a large system. He completed his optometry degree at Pacific University and completed his residency in Atlanta, Georgia. He has his Doctor of Optometry, and he is a fellow at the American Academy of Optometry. Dr. Doe has been practicing optometry for over 6 years and has a special interest in ocular disease management and ocular surgical co-management. He also has experience with the diagnosis, treatment, and management and follow-up of those who have IIH. So with that being said, I'd like to go ahead and come off screen and pass the spotlight to Dr. Doe. Thank you so much for coming today. We definitely looked at our IIH series webinars that we've been doing for the past few years, and we have not been able to host an optometrist, so we look forward to learning a lot from you today.
Perfect. Thank you for having me. Let me share my screen now. So thank you, everyone, for coming today, and thanks for IIH Hub for presenting me or allowing me to speak. I was asked a few times by Edith and the people at IIH Hub here to speak, but public speaking really isn't my thing, so I was hesitant at first, but I know that idiopathic intracranial hypertension is such an important topic, and it takes a whole team of healthcare providers to manage it. And I've been made aware that very little is known of what we do here in the optometry department. So that's really the goal of the talk today, is to discuss what we do here in the optometry department, including the tools we use to diagnose or see optic nerve swelling and help identify people with potential IH. And we'll talk about a couple of cases about that as well that I've helped manage. So I have no financial disclosures. So real quick, what is an optometrist? So we're healthcare providers who, traditionally do perform eye exams and vision tests. We complete a 4-year degree after undergraduate studies. So after you obtain your bachelor degree, you go on to do a 4-year optometry program. And this is solely speaking for optometrists who practice in the States. I know we have a lot of other providers here that may be overseas, internationally. So I'm not 100% sure that everything's the same over there, but at least in the States, we complete a 4-year doctoral degree. We do have an optional 1-year residency after completing optometry school. This is typically for people who want to self-specialize in other parts or other specialties in optometry. So that could include like specialty contact lenses, low vision, pediatrics, ocular disease, just if you want to get a little bit more experience in those fields. And I say it's optional because after you complete your 4-year program, you are a full-fledged optometrist and you can practice as such. So don't need to complete a 1-year residency if you don't want to. But traditionally, if someone is thinking about what an optometrist does, you're going to think that where we do glasses and contact lens exams, which we definitely do, and we traditionally will always be doing that. But scope has expanded, and we do a lot of medical eye exams as well. This includes diabetic eye exams, red eyes, managing ocular diseases such as glaucoma, macular degeneration, many more. We have our treatment. Our treatment capabilities includes, prescribing topical medications, oral medications, and in some states we do have procedural rights, such as small excisional surgery. So it's like sty removals and laser surgery removals, or sorry, laser surgeries to treat glaucoma. Um, but the scope of practice really depends on the state that you're in. So we always say optometry is a very legislative profession. So what that means is the scope of practice varies between states to states. And so it gets a little confusing for the general public, knowing what optometrists really do. And I'm sure the scope of practice is a lot different too in other countries. I don't even, because I practice out here in Oregon, and if you ask me what an optometrist can do in Montana, I'm not 100% sure. So I could totally see what the confusion, or how there could be confusion within the profession. But what optometrists don't do is we definitely don't do any eye surgeries. So any cataract surgery, corneal retinal surgeries, we don't do any of those. And any like more complex ocular cases, I do like to defer them to my ophthalmology colleagues. Um, so there's many modes of practice in optometry. I personally work in something called a health maintenance organization, or an HMO. Essentially, we're just our own healthcare model and healthcare system. We have a whole network of our own primary care providers and specialists all within the same system. The pro of this is that everything is done in-house. I'm able to order, testing, labs, imaging, and directly myself. And if I need to look at a chart note from a primary care provider visit to get more information about this patient, I'm able to just pull that up, within the same EMR or health record system. So it's been pretty nice to be able to, have access to all that stuff. But in optometry, there are many modes of practice. We just listed here. So depending on how you want to practice or your personality, there's likely a mode that's going to make you a bit more happy than others. But yeah, I like the HMO's system that I'm in. So so I'm just gonna go over the typical eye exam flow of someone that comes in for a routine eye exam. So, give or take, there could be more things that we do or less things that we do depending on the specific case. But if you're just asking me about, what goes on in a typical routine eye exam, these are the kind of the bread and butter that is in there, or the meat to the sandwich of what we do. So, they'll come in, we'll take a case history and a chief complaint. So just kind of looking back at their medical history and their ocular history, just taking notations of that. Chief complaint, I want to make sure we ask them what's bringing them in today, so that we could tailor the eye exam, for their needs. And then we'll take a visual acuity. This is when we just take their vision. So if you ever heard of the term 20/20 vision, this is the part where we're checking that. IOP stands for intraocular pressures. So we're just taking their eye pressure as well. Entrance skills, these are just basic eye functions, or eye structures that we're looking at as well. So pupils, we want to make sure the pupils are responding well to light. EOM stands for extraocular motility, just make sure all the our muscles are moving well. CVF stands for confrontational visual field. So just checking closely how the peripheral vision is doing. And then CT stands for cover testing. Cover testing just checks the eye's posture or eye misalignment. So, if you ever heard the term strabismus, that's kind of what we're looking for here. Refraction is when we actually get the glasses and contact lens prescription. And we sometimes use refraction also as a diagnostic tool, because refraction, or the patient's vision, we want to know if they're able to see well, with a pair of glasses or without, or sorry, not without. Let me back up. So on a refraction, we can use it as a diagnostic tool, because say they got good vision with a refraction, then we know their poor vision is due to just them needing glasses. Now, if we do a refraction and their vision is still poor, then we know there's likely some pathological cause that's causing them to have poor vision. So, a classic example of this is that if a patient comes in and have really thick cataracts, doing the refraction is not going to yield them good vision because there's a thick, blockage in their visual pathway. And a cataract is a, clouding of the lens within the eye, which is kind of in here in this photo. There's no cataract here, but this is where it would be. So yeah, so we can use the refraction to kind of help us, kind of fine tune or be in tune to what to look for on the eye exam. And then after our refraction, we go on to do a anterior segment examination. So what that means is just looking at the front structures of the eye. So this is a photo of some of the front structures of the eye. So this beam here is the cornea. We're looking at the iris, looking at the pupil, looking at um, the conjunctiva and the sclera, which is the white part of the eye here, partially in the picture, these lid and lashes. So we're looking at all those things, just making sure everything's normal there. And then we go on to the back of the eye test, so the posterior segment. And this is just a photo of what we see when we look into someone's eye. And we could definitely see a lot better when someone's dilated. So if your optometrist asks you if you could be dilated today, really consider doing that because it's going to allow us to get a better view of the back of your eye. So this is a totally normal eye, but some of the important structures that we're looking at here include the optic nerve, which we'll talk a lot about today, which is this kind of circular thing here. I always tell people the optic nerve head, which is the front of the optic nerve here. As we know, the optic nerve extends to the beyond the eye and into the brain. But as we're examining the eye ourselves, we only see the front of the optic nerve, called the optic nerve head. And I always tell people that the optic nerve head looks like a donut. So you kind of see the donut here, the donut ring here, and then it's really hard to see in this photo, but that's usually a cup or the donut hole. This is where all the blood vessels emerge out of. So yeah, we're looking at the optic nerve, but we're also looking at all the vasculature in the eye itself. And the vasculature is an important part of the exam because it can actually tell us a lot of things or other conditions, systemic conditions that the patient may have. There's many times where a patient would be undiagnosed, like having undiagnosed diabetes, and the first time that anyone would see signs of it is in the eye. But there are other rare conditions as well. There's been a few cases that I've seen where there's specific signs of there's the special, not special, but there are more uh, atypical hemorrhages that you can see in the retina, which may relate to leukemia. So there's a few cases of undiagnosed leukemia that the first signs were in the eye. So yeah, the eye is a very important structure in the whole body system, and it could tell us a lot more than what's just going on in the eye. It could tell us a lot more of what can be going on in the body. And then yeah, and then so I digress. So here, another important structure that we look at is the macula, which is in the very central part of the eye. The macula is responsible for your central vision, so it's a very important structure to look at. And also the peripheral retina, which want to make sure there's no lesions or pathology out there as well. So that's a pretty thorough back of the eye exam as if we look at all those structures. So I'm sure everyone here is very familiar. You're familiar with what idiopathic intracranial hypertension is. So I'll just briefly talk about this. But essentially, IH is when there's high pressures around the brain without a known cause. And how that relates to the eye is that it can put pressure on the back of the optic nerves and lead to optic nerve swelling. And these are some of the common symptoms that you may find in someone that has IAH. So going back to our typical eye exam flow, these are the things that we can generally expect or suspect in someone that has IH. Now, this is very generalized. but because sometimes people may have different symptoms and signs on eye exam than others. But for the majority of cases, at least that I've managed, these are some of the more common presentations. But yeah, in our practice, sometimes the patient that's in my chair is being referred by either their primary care provider or neurologist to specifically check for papilledema or optic nerve swelling in the eye directly. And they might be wanting us to check because they have a suspicion that their patient may have IIH. So their exam with us is solely to check for that. But sometimes, and probably most of the time, IIH is an incidental finding on a routine eye exam. So it's just someone that comes in for their annual routine exam, and we just incidentally just find like optic nerve swelling, and eventually do the workup and they get diagnosed with IH. Typical symptoms of someone with IH that's related to their eye exam or they would report on their eye exam includes chronic headaches, blurry vision, intermittent blurry vision, and maybe some blind spots. These are the demographics you should consider when you are thinking about IH. So, young female with a BMI over 30. Visual acuity in someone with IH may be reduced, but in many cases, these patients actually see really well. They see, 20/20 vision. Their eye pressures, their pupils, and their eye muscle movements are typically normal, and their visual fields are usually also normal unless the optic nerve swelling is very severe. Refraction will typically yield good vision. So again, their vision is usually pretty good. The front of the eye structures usually are normal. There's really not a lot or any relations to IH and the front of the eye. Correct me if I'm wrong. And then the posterior segment, the main thing that we're looking at is papilledema or optic nerve swelling. Now, papilledema technically is a term that describes optic nerve swelling related to IH. When we are seeing a patient for the first time that doesn't have a true diagnosis of IH, we technically can call it papilledema. We call it optic disc swelling. But since this talk is all about IH and papilledema, you might hear me use that term interchangeably. But just for housekeeping, that's generally the difference, I guess. But sometimes papilledema is very easy to tell. So on your left here, very severe papilledema, and then on your right, a lot more milder. Now, it's important for us to be able to see the subtleties of optic nerve swelling in order for us to make a right diagnosis. Because if a neurologist or a primary care provider is referring their patient to us to check for papilledema, you don't want to miss papilledema, or else it may delay their their care or delay their diagnoses. So there are tools that we use to help us identify subtle optic nerve swelling, and these are some of the things that we use. So I'll go over each one of these here briefly. The first thing that we're looking for is something called spontaneous venous pulsation. So I'm just going to play this video here. You don't need the volume. So spontaneous venous pulsation is essentially the physical pulsation of the central retinal vein, which you can see it right here. I don't know if everyone can see that. And the central retinal vein is the vein that exits the optic nerve head itself, and it helps drain the retinal blood circulation out of the eye. And for SVP, or spontaneous venous pulsation, we can use this sign as a tool to help rule out high brain pressure, not necessarily say that someone has high brain pressure. So let me explain. When someone, all right, well, let me back up. So SVP happens or occurs due to the interaction of the intraocular venous pressure and the retrolaminar pressure. So there's two pressure gradients, the pressure that's going on in the eye and the pressure that's going on right behind the eye. And as and you could think of this as like, for simplicity here, that you have the eye pressure and then the brain pressure. So your SVP happens with your blood pressure. So in systole, the eye pressure is actually higher, and when the eye pressure is higher, blood likes to flow from high to low pressure gradients. When blood is higher, or when the pressure is higher, the blood will flow out of the eye through that central retinal vein. And while it's flowing, you're going to see the vein as collapse because blood is continuously flowing out of the eye. But in diastole, the eye pressure is now lower than the brain pressure, and then blood is not flowing out of the eye as much. And when blood is not flowing, you can see the central retinal vein as not collapse. You'll see it as I guess expanded. That's the word I was trying to look for. So that cycle, systole and diastole, you'll see the vein, expand, collapse, and that's the pulsation that you're seeing. So in someone with high brain pressure, you may see now you get this gradient that is no longer patent. So now you're going to always have higher brain pressure than the eye pressure. So now, if that were the case, then you're no longer seeing that pulsation anymore because there's no pressure gradient to allow the vessel to beat, I guess. Uh, so if there is SVP, then we know that this pressure gradient is intact and likely the brain pressure is normal, or at least we could say the optic nerve is not swollen because the pressure is normal. And however, if you have no SVP, we can't really say that you have high brain pressure because about 20% of people that in about 20% of people, there is no SVP regardless in normal people. Let me say that again. In normal people, there's about 20% of them that don't have SVP anyways. So uh, yeah, you can't really say that with with SVP, without SVP, we can't have high brain pressure. Sorry, it gets it gets a little confusing. Um, so yeah, hopefully that all made sense. I'm just gonna move on, but that's generally how we use SVP. Bottom line is, if there's SVP, then usually there's no optic nerve swelling. Okay, so moving on. This is called patent folds or patent lines. These are clinical signs, or this is a clinical sign that we use to help us determine if there's subtle swelling here, optic nerve swelling. So what these patent folds or patent lines are essentially are these radiating lines out of the optic nerve. I don't know if you could appreciate that, but these lines here. And essentially why that's happening is because there's pressure behind the optic nerve and it's pushing the adjacent retinal tissue, next to the nerve. And that push is causing tensile stress on the tissue, and it's causing the tissue to fold on itself a little bit. Um, and this nerve, so the way that we really look for optic nerve swelling is we're looking at these margins. So if these margins are sharp, then we know that there's no swelling there, at least not obvious swelling. What that means is that you could tell where the optic nerve starts and where the retina starts here, but once you start getting up here, you could see that's a little bit more fuzzy, and it's hard to tell where the optic nerve start and the retina starts. But in other nerves, if these margins are a little bit more sharp, we can use these patent lines to tell us that likely there is edema there because of this like tensile stress that's happening. And just a quick like side case, this was a real patient of mine. This patient actually did not have IIH, and uh, this is how when I saw this patient, this is how her nerve looked. And this photo was from a diabetic photo, so she didn't actually see anyone when this photo was taken. She just came in and got her diabetic eye photo screening. But when I saw her in 2024, this is what her optic nerve looks like now. And this was a unilateral presentation, so only her right optic nerve, this is the right optic nerve, was swollen. Her left optic nerve was totally fine. Typically in someone with IIH, you will see bilateral optic nerve swelling. And in someone with unilateral optic nerve swelling, a lot of times it's due to um, a vascular condition. So oftentimes we actually don't image someone with IIH. Or sorry, we don't image anyone with unilateral optic nerve swelling. However, in her case, because she had this photo from 2021, I know that there was something progressive going on that caused her nerve to look like this now. So I did OR imaging for this patient, an MRI of the orbit, a picture of the back of the eye, and so it actually turned out to be related to optic nerve sheath meningioma, which is a benign tumor that can grow behind the eye. And as it grows, it kind of continues to push from the back and cause increased optic nerve swelling. And without treatment, well, sometimes you could monitor these patients just in the clinic as long as their vision is fine and their peripheral vision is fine, then intervention may not be needed. But if they start to get vision loss or peripheral vision loss, then treatment will be indicated, and that may be in the form of like a surgery or like radiation therapy, things like that. So yeah, just a side note there, but I'd use these patent lines to tell me that there likely was swelling, back in 2021, um, as well as, 2024, which is a lot more obvious. All right, moving on. So there are techniques and tools in eye care that allows us to really visualize the structures of the eye. This machine here is probably the most revolutionary machine that has come to eye care in a long time. This is called an optical coherence tomography, under OCT. I think it came out in like the early 2000s. But essentially, it uses a non-invasive imaging technique um, to create a cross-sectional image of eye structures. So not only can it image the optic nerve, it also can image the cornea, which is what you're seeing here. So we could really see that all the different layers of the cornea. The angle is this little kind of triangular area here. You've ever heard of the condition like narrow angle glaucoma? This is a kind of one technique or one way we can use to look for risk involving that. And I won't get too much in these other conditions, but yeah, just wanted to illustrate that this OCT machine can help us see a lot of different structures of the eye. This is an OCT scan of the macula, so that central part in the back of the eye. And this patient actually has a little bit of macular degeneration. So yeah, we could help manage patients' eye conditions by using this machine. And of course, this is a scan of the optic nerve. This is kind of like the raw scan of the optic nerves. We generally don't look at this like scan. When we do a scan of an optic nerve, it spits us out a printout that looks like this. Now, I won't go through every single thing on here because I could get to be its own lecture. But essentially, what this machine does is it breaks down our optic nerves into sections. Um, so as you remember, I told you the optic nerve kind of looks like a donut. So you can almost see that here, or at least you could maybe visualize this here. And it gives us like a raw value or a quantitative value of how much optic nerve tissue is in each section. And we can use this to kind of gauge different conditions. So a lot of times we actually use this scan to monitor glaucoma. In glaucoma, you get loss of nerve tissue over time. And so we can, do one scan as a baseline, and then, maybe 6 months or a year later, we do another scan, and we compare these raw numbers to that new scan to see if there's any loss of nerve tissue. And if there's loss of nerve tissue, then it could mean indication of progressive disease. In IH or papilledema, these values will artificially be higher because there's swelling and it's pushing these tissues above or elevate the tissues, and these numbers will be artificially higher because you can't gain nerve tissue. Your eyes can't generate more nerve tissue. So using like our clinical correlation, we can infer that this increase in value is from swelling of the nerve. So we'll look a lot more at these printouts as I go over my cases later. Um, this is a Humphrey visual field test. This is like, in this gold standard for checking your visual field or peripheral vision. We don't generally use this machine to determine if there's like optic nerve swelling, but it can help us determine other defects that may not be related to IH. So for example, there's a condition called oh, someone's iPhone is going off. uh, oh. So, anyways, there's a condition called non-arteritic ischemic optic neuropathy, and that condition has a very specific optic or visual field defect, and that can also show as optic nerve swelling. So, just an example of how we can use this machine to differentiate different types of causes of optic nerve swelling. But yeah, in a visual field test, you typically will get a printout like this. And again, I'm not going to go over each little detail on this printout, but for the sake of this presentation, I would just focus your attention to this area here. And in this printout, the patient has a normal visual field, no defects here. But in patients with papilledema, you may get different types of visual field defects. A lot of times, though, patients with mild and even moderate papilledema generally have a normal visual field that looks like this. This little black spot here is your natural blind spot. So everyone has this natural blind spot. But in papilledema, sometimes you get an enlarged blind spot. So that blind spot just gets a little bit larger. And then this is called a nasal step. And then an arcuate scotoma, there's not a picture of one here, but essentially you just get a more extension of the nasal step. So an arcuate defect kind of looks more like a arc. Oh, it looks more like an arc like this, and then you could also be superior as well. And then if you get pretty severe or chronic papilledema, you can get an entire like constricted visual field as well. So this is why it's important to can help control the papilledema or help it resolve because chronic swelling can lead to peripheral vision defects. And so now that we've identified optic nerve swelling, what do we do now? So again, touched base on this earlier, but yeah, papilledema is defined as optic nerve swelling from IH. And if we're seeing optic nerve swelling for the first time, where we technically can't call it papilledema until they're been confirmed that it is IH. So we must first rule out other causes of optic nerve edema, because there are many other causes other than IIH, which can include tumors, certain medications, vascular conditions such as hypertension, diabetes, and so on. And so for two of the imaging that we pretty much always order for cases suspected of IH is the MRI to image the brain and the MRV to image the veins in the brain. And the MRI rules out any like masses and things like that. It could also show us signs and characteristics of IH, which the report can come back. For some of these, you might have seen this before. Epicella, distended optic nerve sheaths, etc. The MRV rules out a cerebral sinus thrombosis, so essentially blood clots in the brain. And then also it can reveal something called transverse sinus stenosis, which I'm sure people are familiar with as well, but we'll touch base on this a bit more later. And then as long as those two things come back normal, we then proceed with a lumbar puncture to get the brain pressure. And my source that I got, this is what the normal was listed as. I don't know, but correct me if I'm wrong. I know there's a neurologist probably in this presentation right now. So yeah, let me know if these numbers seem accurate to you guys. Let's see. So once IH is confirmed, a referral to neurology is usually made to manage manage them systemically, and treatment usually includes weight loss and then starting them on some sort of medication. And if the medications aren't helping control the other symptoms or the papilledema, then surgery may be recommended to help control it better. So what is our role in the optometry department? We have the patient come back regularly for dilated eye exams to one check the papilledema just to make sure that there is improvement or not worsening of their papilledema. We also check their vision, just make sure that they're not having any vision loss. And we also check into peripheral vision, just making sure that they're not developing any peripheral visual defects. And typically, I do like to see my patients back in 4 to 6 weeks after they've seen neurology and started medications. It gives us a little time for the medication to work, and we could maybe see more of a change in the optic nerves a little bit more as we you know space their follow up out a little bit more. And as long as everything is stable or improving, we'll extend their follow-ups in the eye clinic to 3 to 6 months. And then if things are pretty stable, then we'll go on to a annual type of follow-up. But however, this is just very generally speaking. Depending on the case, I may see the patient back sooner or later. Yeah, just really case dependent. But this kind of gives you a general idea. The patients generally also being managed by neurology concurrently. And again, if papilledema is not improving, we do uh, want to maybe consider referral to neurosurgery or oculoplastics to consider some sort of surgical intervention. So this brings me to the cases that I'm going to talk about. My first case, I titled it Keep It Mild. This case starts with a 33-year-old African-American female who presents for a routine eye exam. Her chief complaint was that she had intermittent episodes of blurry vision in both eyes that started recently. She has a medical history of migraines. She has been on amitriptyline since 2021. I think she's using this medication to help with preventing her migraines. She does have a history of obstructive sleep apnea, and her BMI was 43.5. And her exam findings, her entering vision, so her vision without any glasses was 20/30 in both eyes. OD stands for right, OS stands for left eye. Eye pressures were normal. Normal eye pressure is somewhere between 8 and 22 about. And typically eye pressure isn't actually affected in someone with IIH, so it's not a value that we're really worried about unless it's elevated. Then we have to figure out why it's elevated. But generally, you don't get elevated eye pressure with IH. Her pupils, her eye muscle movements, and her visual fields were normal. We did her refraction, and this just tells us that she has farsightedness with some astigmatism. And BCVA stands for best corrected visual acuity. So she's able to see 20/20 with glasses, essentially, is what that means. So great, she has great vision. Her anterior segment was unremarkable. Front of structure of the eye looked fine. The back of the eye looked like this. Now, I would say the right eye has a little bit more subtleties in the optic nerve swelling than the left eye. Remember, I told you earlier, we kind of look at the sharpness of the lid margins, or sorry, not the lid margins, the rim margins. Um, and you could tell exactly where the optic nerve starts and then where the retina starts. On the left eye, over here, we call this the nasal side of the optic nerve, um, the rim margin's a little bit more fuzzy. And so I would say you have a little bit more disc edema on the left eye than the right eye. And again, we can see these patent lines a little bit as well, which can help us be more confident in our diagnosis. And there are like grading scales on optic nerve swelling or disc edema. I didn't include that in today's talk, but just know that there are like formal gradings for disc edema. But here's what her OCT of her optic nerve looks like. And you can see down here, looking at these values, the value below it is a percentile, and it kind of gives us, it compares her value to a normal database of normative values, and you can see that she has well above the 99th percentile of the norm. And again, you can't gain nerve tissue, so we can infer that she has optic nerve swelling, and that's why the values are elevated. This is a neat chart to look at as well. Um, the ones in the black, this is what her optic nerve tissue number is. So it's saying that she has a lot of nerve tissue, but again, because it's swollen. Um, the one, the line that's in the green and the kind of area in the green is where she should be, or at least that's what the average is for someone her age. And so you can see that she has well above the average than the than where she should be. So that's her right eye on the left side, and this is her left eye on the right side of the screen. And you can see that the left eye has quite a bit of swelling as well, probably more, yeah, more than the right eye. And here's her visual field. And again, we're just kind of worried about, or we're just going to look at this area down here. And her peripheral vision looks great. There's really no defects that we're seeing right now, which is very, very good. So the next steps, we then went and proceeded to order an MRI and an MRV. And both of those were ordered on an outpatient but urgent basis. So usually when we order some imaging that's urgent, we get it done, or the patient gets it done in about a week or so. And that's the nice thing about working in an HMO setting is that we can directly order this ourselves, and we don't have to, message their primary care to put the order in or anything like that. For example, if an optometrist were to work at like say a private practice, sometimes you have to like send a letter to the primary care provider, and then the provider has to then order the testing, which can delay their care. And or if a private practice optometrist wants the testing more urgently, they'll have to refer the patient to the emergency room for these testing, and that could incur like a cost for the patient, and it could also clog up the emergency room for something that may not necessarily need to be imaged same day. So yeah, just a good uh, pros and cons, but pros of working in the HMO system. But for this particular patient, her MRI and MRV was totally normal. So then eventually an LP was ordered, a lumbar puncture was ordered, and her opening pressure was 33. She was referred to neurology for a consult and was started on Diamox, 500 milligrams twice a day. And she was instructed to follow back with me to check her optic nerve edema and see how she responded to the Diamox. And she was also recommended to work on weight loss. So I see her again about 2 months from her initial visit, and probably about like 6 weeks from her, maybe more like 4 weeks from her starting the Diamox. And she states that on this exam that her symptoms were improving. She was getting less headaches. Her vision was still really good, and then her papilledema had improved in both eyes. And the plan was to continue her medical management with neurology, and I'll follow up with her in 3 months for another optic nerve check, and I will repeat the visual field at this time. This is her optic nerve scan from that follow up with me. And again, and this is just the same information, just a little different printout, I guess. But you can see here the black lines. So the top one, so yeah, the top scan is her initial visit, and what this does is it compares her initial visit with her current visit. And so you can see the dates here, about 2 months apart. Um, and so you can see that this black line is a little bit lower, getting closer to that norm. And if you're looking at these numbers, you can see that these numbers are reducing as well. And this graph over here is kind of showing us a picture view or color view of that decrease. And again, it's not like she's losing nerve tissue, but we can infer that, because she had optic nerve swelling, that her swelling is reducing or getting better. Same story on the left eye as well. Here's another like analysis printout of this of the same information. This is essentially just comparing this number to these numbers over here. Again, this one in the red box is her initial visit, and then this one out here is her follow-up visit. So, TS stands for temporal superior section of her optic nerve. And you can see that from her initial visit to her current visit, she had a loss of 30 tissue or 30 units from her initial visit. So we can see that's improving. Now, I don't like to just go and do math on all of these extra sections. So this is a nice kind of grayscale area that does the math for you, so you could quantitatively see how much improvement her optic nerve swelling is having. And this is the right eye, and this is the left eye. And left eye is showing a little bit better improvement as well. So all looking good. And let's see. So I follow up with her again 3 months later. So about 6 months after I first saw her. She's still doing well at Diamox, no side effects. She's still on the same dose. She's seeing 20/20 in both eyes, right and left eye. Papilledema completely resolved at the 6 month follow up with me. So that's looking really good. And her visual field continues to look good in both eyes. So her plan is to continue her medical management with neurology, and then we'll extend her follow-up eye exam to about 6 months. And this is her optic nerve scan at that 6 month follow-up. And you can see that she's pretty much in the green now in both eyes. So her swelling has definitely improved a lot. And yeah, so now I'm just seeing her or I've had been seeing her on a 6 month basis for the last 3 years. She's recently developed some mild shortness of breath, or shortness of breath with her Diamox. So neurology is working on reducing her dose, and then eventually stopping it completely. So I do have an appointment. She does have an appointment with me next month to recheck the papilledema. So I'll see how that goes. But yeah, that's case one, kind of starting off pretty easy. This is case two. This is I titled this stubborn IIH, and you'll see why here. But this case starts with a 47-year-old Caucasian female who presents for an eye exam referred by urgent care. This patient describes, or her chief complaint was that she was having headaches and quote unquote visual disturbance. Her medical history, she has a history of headaches, and her visual disturbance was described as lights in the peripheral vision in both eyes. That started a few weeks ago, which prompted her visit to urgent care. She does have high blood pressure. Blood pressure in urgent care was 168 over 100. She does have a BMI of 38.8, and she has common migraines. Now, in her eye exam with me, she's seeing 20/20 vision, both eyes, with her glasses already coming in. So, really good vision. Her eye pressure is normal, kind of on the upper range of normal, but overall, normal. Pupils, eye muscles, and her visual field, gross visual field was also normal. We did a quick refraction. She's a bit nearsighted, but that also yielded really good vision. The front of the eye looks great. No problems with the structures in the front of the eye. The back of the eye, only pertinent findings were these swollen nerves, and you can see these nerves are a little bit more swollen than our last case, so it's a little bit more obvious. She's having like 360 nerve swelling in both eyes, and this is her optic nerve scan, and you can see that she's just kind of above the average here, and her visual field was overall fine. You got these little non-specific defects that could just, overall be a user error type of thing, but these aren't any specific patterns of defects. So I would say overall her visual field is full in both eyes. So again, we ordered an MRI and an MRV on a urgent outpatient basis, and they came back normal. This is just I just copy and pasted this from the actual report. So yeah, no, and yeah, this is like a typical report we would get, but everything, yeah, looks fine. She actually saw her primary care provider before seeing neurology, and her family care provider started her on Diamox at a pretty low dose. Um, I'm not sure the reasoning behind that, but that's what she did, or that's what happened. And then she was referred to neurology for a consult. She did say that her headaches and the pressure feeling has improved, but she has been getting more nausea and vomiting and diarrhea from the Diamox. But after discussion with her neurologist about the risk of IH and other alternative medications, she decided to kind of stick it out and try to increase the Diamox dosage to 250 milligrams twice a day. She then eventually did get a lumbar puncture, which confirmed the diagnosis of IH as her intracranial pressure was a bit elevated. Um, so 2 months after I first saw her, I see her again for an eye exam. She tells me she's tolerating the Diamox okay, but she was still having some of the same symptoms as described. But she did say it has improved. Her vision was good, 20/20 both eyes. Papilledema was mildly better in both eyes. It's getting a little better, not fully resolved yet, but a little bit better. And I relayed all this information to her neurologist. This is her scan here, and you could see that she's almost in the green in the well, there's one area that's a little bit elevated on her inferior optic nerve. That's what this INF stands for, but the rest of the nerve looked fine. Remember, we started with more of a 360 um, elevation of her nerves, so this is pretty good improvement that now only one sector of her nerve is swollen, and then her left eye, all around is getting better from here. And again, this is that other scan that tells us the change from her initial to her follow-up visit. And all these minus numbers are showing us that things are improving. So in between eye exams, she's has been seeing her neurologist. She had increasing levels of nausea and vomiting, and then she also developed fatigue and GI upset with the Diamox. So they stopped Diamox, and then they started a different medication called topiramate. Topiramate works by reducing CSF production, cerebral spinal fluid production, which then lowers your brain pressure. It also can help with weight loss and migraine prevention. She did much better with topiramate initially. However, after 6 weeks of being on topiramate, she started to have increased anxiety, irritability, paranoia, and even start having like suicidal thoughts. So they quickly stopped that medication, and they are trying now furosemide, which is a diuretic. It's used sometimes for high blood pressure. And it also works by reducing CSF production to lower the brain pressure. So 4 months after her initial visit with me, she states that she's tolerating the furosemide really well. There's no side effects at the time of my exam. Her vision was great, 20/20 both eyes, and her papilledema was a lot better on this visit. And again, I relayed all this information to her neurologist. And here's her optic nerve scan. So pretty much all in the green now. That kind of stubborn inferior disc swelling has definitely improved. And yeah, these are some of the follow-up, you know, analysis here. And yeah, the numbers are continuing to improve. The top is her right eye, the bottom's her left eye. Well, yeah, I think that's right. All right, and then we then again follow up again, and I guess that was a 2 month interval. So I see her again 2 months later, or 6 months from the first time I saw her. Again, she's still tolerating the furosemide well, no side effects, vision still good. However, the papilledema has looked worse now. And again, I relay this information to her neurologist, but here's her scan from that follow-up visit, and it's getting just a teeny bit more elevated. And you can see these numbers. I guess you can't see the numbers, but yeah, the numbers on the side here are increasing, and then you can see on her black line here, it's kind of going up a little bit. And this green is saying that she quote unquote gained nerve tissue. Remember, because before when we saw red, it's showing that she's losing nerve tissue, but again, they're using clinical correlation, we know that these are gains these are improvements or worsening of optic nerve swelling. And so, yeah, her swelling is just a teeny bit worse here. Now, she's still tolerating the furosemide well, and furosemide did work well initially. So we're not 100% sure why it's continuing to worsen now. It could be like maybe more intolerance to the furosemide. Maybe she's not as compliant with the furosemide as before. Not 100% sure. But they did try to increase, neurology did try to increase furosemide to 30 milligrams. And the plan was to, have her check with me again to see how she's responding to it. And then, increase it even more if the swelling is not, improving. And then just to note, she did lose 40 pounds since she was first diagnosed. So I see her again after they increased the furosemide dosage. She did report mild dizzy spells with the medication. Her vision was good. Papilloma, unfortunately, though, was continuing to worsen in both eyes. So here again is her follow-up optic nerve scan. And you can see now that the black line is now above the green, the normal green. The left one's holding a little bit better, but also elevating a bit. These are her follow-ups, her last two follow-ups compared to her initial follow-up. And, well, I guess this is not her initial follow-up. This is when her um, this is a follow-up when her optic nerve had improved. The reason why is we had a software update, so it couldn't compare her initial follow-up um, with us or with her new ones. So this baseline here is a visit that she had improvement in optic nerve swelling. So from that visit, we can see now that she's increasing or getting a little bit more swollen. And because these numbers aren't negative, that means they're positive, and that's saying that she quote unquote gained nerve tissue. And again, that just means that her swelling is worsening. And yes, worsening both eyes. Fortunately, though, her uh, visual field looks good, so no peripheral vision defects from her swelling. So that's always a good thing. And so again, she saw neurology again. They were planning on increasing her furosemide dosage, but because the papilledema was increasing, they didn't feel like increasing the furosemide would have made a difference. So they did refer her to neurosurgery. The neurosurgeon reviewed her MRV from that initial, testing, and they did see that she had bilateral transverse sinus stenosis, the right side more worse than the left. She eventually underwent something called venogram. That's just checking the transverse sinus and the sinus next to it, the sigmoid sinus pressure gradient. And a normal pressure gradient between those two sinuses should be less than 8, but this is showing that the gradient is over 20 or is 28, so it's a bit high. And I'll explain that a little bit more in a second. Neurosurgery, because of this, recommended her to have a right transverse sinus stenting, and she agreed with the plan. So real quick, we'll talk about how the transverse sinus relates to IIH. So if you can see here, get this. Hang on, that little thing is in my way. I'll move it over here. Um, oh, I guess I was in everyone's way. Sorry about that. This is a schematic of a brain picture, I guess. And the green is where the transverse sinus sits, and then it, transitions to sigmoid sinus, which is kind of this, I guess, bend here. And the sinuses, what they do is they function to drain venous blood from the brain. And many patients with IH will have a stenosis or narrowing of the venous sinus, which can then lead to high brain pressure. And that gradient that I was talking about at first, I think what that does, it just measures um, how much pressure is going in here. So I guess it could be inferred that if you have high gradient pressure, then the reason is because the sinus is more narrower. Again, I'm not a neurologist, so correct me if I'm wrong, if there's any neurologists here. But so, anyways, there are studies that are trying to see the relation between the transverse sinus and IH. We do know there's some relation because in about 90% or so of patients with IH, they have some extent of a narrow or stenosis transverse sinus. However, the severity of the transverse sinus doesn't necessarily tell us the outcome, the visual outcome, or the severity of the papilledema. So it's not like a one-to-one relation, because sometimes you can have a very narrow stenosed transverse sinus, but mild papilledema, and vice versa. But essentially, what stenting does is it opens up that sinus and should increase the outflow of the venous blood and CSF, which then in theory lowers the eye pressure or the brain pressure. This is a photo of or an MRV of one's transverse sinus being a little stenosed. And these are just some studies or articles that you can read about relations between sinus stenosis and transverse sinus stenosis and visual outcomes in IH. And let's see. These photos I stole from I think a neurosurgeon, Dr. Kim. He also presented here on IH at some point. So shout out to Dr. Kim if you're on or seeing this. But essentially, this is someone's transverse sinus that it's pretty narrow, and then after he stented them, it's a lot more open. Um, and she went and got the stenting. Just now going back to her patient, she went and got the stent, and this is the first follow-up of that I saw her for, and she's doing really well. She's not on any medications anymore, and she has improved symptoms overall. Vision is excellent, 20/20 in both eyes, and her papilledema was markedly improved, and it looked essentially resolved. And this is her optic nerve scan at that time, very well in the green. And I actually have photos of her optic nerves before and so when I first saw her, and then after I saw her. And these are different cameras. That's why the picture coloration is a little different. We had an update on our camera in the clinic, but I promise you, this is the same optic nerves. You could tell from, these are the blood vessels. The blood vessels, the retinal vessels are pretty unique to a person, so you can see that these are the same, blood vessels. So, anyways, so yeah, you can see when we first started there, 360 optic nerve swelling on this optic nerve, and now it looks a lot better. Same with this eye. You could see the big difference there. Her visual field continues to look great, so always a good thing. And yeah, so she actually moved away. So I haven't seen her for several years now. So yeah, hopefully she's doing well. All right, so this is my last case I'm presenting. Hopefully we're doing okay on time. We're about an hour. But yeah, I'll go over this really quick. Has some good things in here. So this is case number 3. I titled it Friday at 5 p.m. because, of course, this came in at on a Friday at 5 p.m. But this case starts with a 28-year-old Hispanic female who presents for an urgent eye exam for double vision. Um, Her chief complaint was double vision for about 5 days, and she had a headache with it as well. She was seen in the emergency room 2 weeks prior for a headache and neck pain, and she describes like vague blind spots while she was in the ED. And from the ED notes, it looked like all they did there was they did a CT of her neck, and then they ran some labs, and those came back normal. She does have a medical history of hypertension, and her BMI was 43.94. She has mild obstructive sleep apnea and also high cholesterol. So a lot of things going on for just a 28-year-old, unfortunately. So just some foreshadowing. You could actually get double vision from with IH by the cause of damage to the sixth cranial nerve, the abducens nerve. And the cranial nerve is a nerve that rests, or I guess it's located in the brainstem, but its functions to I guess move the lateral rectus muscle of the eye. The rectus muscle is one of 6 extraocular muscles of the eye. So you can see them here. They kind of enclose the eye on the outside. And their job is to kind of move our eyes around. So if we're looking up, down, left, right, we're using our extraocular muscles to do those things. Specifically, the lateral rectus muscle, which is again controlled by the cranial nerve 6, functions to move our eyes laterally. So in the right eye, it helps us look to the right for the right eye, and then the left eye helps us look to the left. So in patients with IH, you could get a palsy or a damage to the sixth cranial nerve, and you will get double vision because now the eye can't move outwards, and so it's almost like pointing inwards, right? We call that esotropia. But now that if this muscle isn't working, then it's pointing inwards, and because it's pointing inwards, one eye is looking at one direction and the other eye is looking at a different direction, and that's leading to double vision because now your eyes are giving your brain 2 different images, and we call that binocular double vision because if you close one eye, then you should see single vision again. But yeah, so this is what her exam findings were like. So she came in already wearing glasses, and her vision was 20/30 in both eyes. Um, eye pressures are normal, 18. Pupils look normal. Her gross visual field, she did have some restriction on her left field in the right eye. So, her right eye had she couldn't see some peripheral vision on the kind of the left side of her field. And then when we did her eye muscle check, her right eye wouldn't go to the right all the way, or at least it struggled a bit going to the right. So that was really suspicious for a right cranial six palsy. And then on her refraction, she was a bit nearsighted, with some astigmatism, but that actually yielded really good acuities, 20/20 vision. Her front of the eye looked overall fine. She had some dry eyes, but overall looked good. Posterior segment looked like this. Now, this is very obvious that there is, pretty severe disc edema there. It's so severe to a point where it starts to push so much pressure on the blood vessels around the optic nerve, and it causes them to hemorrhage. She did have other retinopathy, so it's not seen here, but the rest of the retina, there was just a few like hemorrhages here and there. So IH isn't the only thing that we're thinking about in this case. We're thinking about other things. Maybe high blood pressure is causing her to have these disc edemas. Um, but the workup is similar. So let's see. This is her optic nerve scan. You could really see the elevations there. This is her peripheral vision test. So she does actually have some peripheral vision defects here. This is her left eye, and this is her right eye. On the left eye on the left, right on the right. And she has these inferior arcuate defects in her left eye. She has these superior and inferior arcuate defects in her right eye. So for her case, because she was showing some neurological symptoms, such as like, double vision, she did have a cranial nerve 6 palsy, and she had very severe disc edema. So instead of, doing an outpatient imaging for her, we directly sent her to the emergency room. And again, this is a nice thing about working in the HMO. I could just call the ER and tell them, what we're seeing, and kind of notify them that she's on her way. And in the emergency room, they had done both the MRI and MRV, and overall, pretty normal findings. She does have some transverse sinus stenosis, but overall, no concerning findings on her MRI or MRV. And she did get a lumbar puncture, also in the ED, or at least I think she was admitted or something, but she got it in the process of being in the ED, and her opening pressure was quite high at 47. And she was started on Diamox again, 500 milligrams twice a day. Um, so she eventually saw neurology outpatient, and they had recommended her to increase her Diamox to 1,000 milligrams twice a day, just because of her, severity of her papilledema, and also her opening pressures were quite high. And she's also seen her primary care provider who's managing her blood pressure. Um, so we follow up with her about 2 weeks later. She's overall doing okay. She thinks vision is a bit better. Double vision is improving. Her vision still pretty good. Papilledema, though, that didn't look really changed. It looked about the same. She still had pretty severe hemorrhages. She still also had a mild right cranial nerve 6 palsy, but it did look a little bit improved. There was no immediate concern just because she hadn't started her medication that long ago, and it was a pretty short time that I've seen her again. So her, nerve edema, wasn't really expected to be that much more improved. However, she did show a bit worsening on her visual field defects. Yeah, unfortunately. And yeah, we really lay all of this information to her neurologist. Again, this is her optic nerve swelling or optic nerve scan that's showing the swelling. And yeah, overall looks pretty similar um, to before. Her visual field, the left eye actually looked maybe a little bit better. The right eye looked a bit worse. It's not extending past this vertical midline, is what we call this. So a little bit worse on the defect. So at this point, I made the referral to establish with an ophthalmologist just because of the severity of her peripheral vision loss. And then also, I just wanted her to establish with an eye surgeon just in case a surgical intervention would be needed. But she's still managing her dose with neurology, and she's managed some other medications. And because of these medications, they decided to keep Diamox at 1,000 milligrams twice a day. I did give her some Fresnel prisms. Fresnel prisms are uh, essentially helps with your double vision, but on a very temporary basis, because we know that because of her cranial nerve 6 palsy, which will improve over time. Um, you know, it helps her kind of get by for now without having to see double vision. Essentially, what we do is we tape prisms on one side of the lens. Sometimes we could do both, but for her, we did one side of the lens. This isn't her, by the way. It's just a picture I should pull up on Google. But yeah, and what it does is the prisms, because the eyes are misaligned, right? So her right eye is turning inwards. The prism essentially brings the image to her eye, so her eye doesn't have to come to the image. Because naturally, when you have two working eyes, they are supposed to be pointing at the same object. But if one eye physically can't point to that object because of her, nerve palsy, then we need to bring that object to her eye. And there's these prisms that we could put on glasses to, do that. And this image is kind of showing that, this her eye here is focusing, at this angle. And if there wasn't a prism there, it will be, looking out here somewhere. But because there's a prism, it's shifting that image to the eye, or it's shifting it to where it needs to look. So that's something we could do for a patient, and it's very easy to as the eye and the muscles improve, we could easily just take the tape off her glasses. Sometimes people need prisms permanently, and we could grind them into the lens. But in her case, we suspect it's temporary. So yeah, tape works great. So now she is being followed with ophthalmology. And again, that's the perk of working in HMO. I could pull up her charts from the ophthalmology exam to report to you guys here. But yeah, she does report subjectively worsening vision and peripheral vision in this exam with ophthalmology. Her her right eye and her left eye vision, though, looks actually pretty good. Optic nerve swelling, however, was markedly better, was a lot better. Her peripheral vision test, though, was somewhat worsened. And here's our optic nerve scan, which looks way better than when it first started. And her optic nerve or her visual field test is a little bit worse. Now that you get some defects kind of extending in her left eye, and her right eye, maybe extending a little bit as well. And that this can happen when you have chronic or severe optic nerve swelling. It may take some time for your nerves to start to atrophy or die away. And the nerve is the pretty much the cord from your eye to your brain. And so if you start losing nerve tissue at certain sections of the eye, it's not relaying that information to the brain as well anymore. But there could be a delay in loss of the nerve tissue following a swollen nerve. So this could is what's likely explaining her worsening visual defect. However, at some point, we do expect it to stabilize because the nerve swelling is improved and almost gone. So we do expect it to stabilize. Unless she gets increasing swelling, then it can progress again. Um, so yeah, she's still managing with neurology. At this point, she has subjectively worse vision. So she's saying that her vision's worse and her peripheral vision is worse. And so they had decided to refer neurosurgery to maybe consider some sort of intervention, surgical intervention. Again, she was found to have a stenosed right transverse sinus. She was given the option to either continue medical therapy or try a stent, but she ultimately decided to continue medical therapy. So the plan was to just really follow her closely in the clinic to gauge or monitor her vision, her peripheral vision, and also her optic nerves. Neurology eventually did increase the Diamox to 1,500 milligrams a day. Um, He has lost 30 pounds since initially having her diagnosis. And then eventually she did report that her vision was stable, no better, but also not getting any worse. And then this is her another follow with her ophthalmologist. No changes in vision, good vision, objectively good vision. Optic nerve continues to be improved. But now her scans actually show some atrophy of the optic nerve, which, like I was mentioned earlier, can happen a little bit later after the initial like swollen nerve. Her peripheral vision testing this time actually was stable, so that's good news. Um, and here is her optic nerve scan. So now instead of being elevated, you actually start losing nerve tissue, and you could kind of see this in the red here. Um, and so yeah, that can happen. Unfortunately, some loss of nerve tissue is um, permanent, so you can't gain the nerve tissue back. But her nerve loss does correlate with her peripheral vision defects here. But overall, overall pretty stable here. So as long as the central part isn't affected, she should have really good central vision. Um, so yeah, she's continued to be managed by ophthalmology, continues to have improvement in her vision, I guess, or yeah, or stability in her vision. Visual field defects are stable. This patient is actually trying to get pregnant, so they did wean her off on Diamox, but now they're just watching her very closely to make sure she doesn't get any recurrence of the papilledema now off of Diamox. She has been stable so far, so happy ending there. And this is the last slide, I promise. So one other thing that or not we, I guess, what eye care can offer for patients with IIH is something called an optic nerve sheath fenestration. I would say though, this is probably reserved for those who have, really progressive vision loss or peripheral vision defects. Because what it does is essentially cuts out some of the optic sheath tissue to make room for, or at least what it does, it relieves the pressure off of the optic nerve itself by removing tissue from the back of the eye. It doesn't necessarily treat the IH, like the patient will still have high brain pressure, but it does relieve some of the pressure off the eye, and the papilledema should improve, and hopefully that will stabilize their vision and peripheral vision. But yeah, it's usually performed by an oculoplastic specialist or a plastic surgeon. And it's interestingly, technically, if you do one eye, it only will relieve pressure off of the one eye. But studies have shown that if you do one eye, it can also show to relieve pressure off of the other eye as well, or the swelling improves on the other eye, which is not clear why that may be, but something interesting. So that's pretty much it that I have for you guys. Thanks for sticking with me here. Um, yeah, any like questions I can answer for anyone?
Thank you very much. That was incredible. To your point, packing in a lot of information in 1 hour, and you can obviously go on tangents with some of this, like interpretation of OCT, et cetera, in its own hour plus lectures. But
Sure.
we really just wanted to bring you on because patients do go home with that piece of paper and it literally like is, I can't even explain what I'm looking at there when, they show us that. So I can't imagine. So it was helpful for you to kind of break some of those pieces down and, patients want to be more informed and they want to hear it
Yeah.
from other providers because when you see the same doctor year after year after year giving you the same answer, it's nice to hear, a fresh face like you, someone who's outside of that, to kind of say, hey, yeah, this is what we do, and these are our options, and this is like within the confines of our profession. We had some comments, but due to time and because we went a little over, I am going to send you an email with some of these questions and then I'll relay it back to them. Also,
Okay.
we'd like to add you to our patient provider page. So if anyone wants to see you as a patient and you live up in the Pacific Northwest or want to make a nice trip, they can
Mhm.
see you as a patient.
Sounds
We're
good.
so grateful for your time. And if, anyone on this webinar wants to hear a different topic from Dr. Doe, we'll present it to him and hopefully get it to you guys within a year or so, because that's about as long as it took for us to get you this time.
Oh,
But
sorry about that.
no, we're so grateful for you and we appreciate your time and your hard work. And like I said, I promise whoever's on the chat that I can connect you with some of those questions.
Mm,
And we hope to see you in the future.
sounds good. Yeah, thanks for having me. Yeah, I'm happy to answer anyone's questions. So just send me an email. I'll leave my email down there for you.
Thank
Um,
you.
yeah,
Thank
yeah,
you.
happy to do that.
Thank you very much. Well, have a
Thank you.
great day, great rest of your summer. Thank you everyone for your comments and questions. Like I said, I promise you, I will get it to Dr. Doe for an answer.
Thank you.
You're welcome. Yeah.